Sir, Dipali here.
Yeah.
Madan sir has already logged in, and
Okay.
Vishal sir will join as soon as he gets free from hospital. He has some cardiac emergency,
Okay.
of neighbor's emergency, so he's at
Okay.
hospital, sir.
Okay. Okay. No problem.
Out.
Right. So Gunwan bhai, you have called him?
So I have called him, sir. He will join as soon as he can, sir.
Okay. So Rakesh,
Yes, sir.
Rajesh bhai, shall we start?
Yes,
Yes,
sir.
yes, we can
Yep.
start. Sure.
Yes, we should start. Let them join. Dr. Madan, Dr. Tarun.
Good morning, Viraj.
Good morning, sir. Good morning. Good morning, sir.
Good morning. Okay, so Rajesh bhai, with your all permission of the expert.
Yes.
So there are some ground rules you must be knowing that we will let him finish the history part. We'll stop him
Okay.
then, and then we can ask the question regarding history. After that, let him examination, and after examination, again we can stop and start like that. So let him finish history first. And Viraj, do not take too much of time, 4-5 minutes for history, 4-5 minutes for examination in between. So we can restart again once he completes the history from slide 1, and you can ask whatever questions you want to ask. And then later on, Viraj, you have got also the investigation slides also, I think.
No, sir.
Because this is not actually exam, so we can have, okay, let us have a discussion, because we can have a Doppler or angio or whatever is done in those. If it is there, you can even tell some of your friend to, if it is available. So later
Yes,
on,
sir.
experts can discuss it better with the presence of, it's okay, doesn't matter.
Sir, I have a picture of the CT angio plate, sir.
But that would be, Tarun, I think that would be good to discuss later on. Okay.
Yes, sir.
Rajesh,
Yes, sir.
I think that should be all right. So upload
Yeah,
them.
that should be
Some, later on, we can have a discussion. No issue. That's fine. Okay. So with permission of all the experts, let us start with it. Gunwan and Vishal will join as they will come free. Okay. Viraj, let us start.
Good
morning.
Thank you all the experts for joining such early on Sunday. Dipali,
Yes, sir.
so you take over if required. I am there, but I'll have some work, so I will be in between. Okay, let
Okay,
us start.
sir.
Sir, I
Yes.
just got a message. Hello, I got a
Yes.
message from Vishal. He is probably busy in emergency. He'll be joining in half an hour.
I think we already talked. I think
Apurva, can you hear me?
Okay.
Apurva,
Gunwan,
can you
you
hear
have
me?
joined. Welcome, sir.
Yes,
Thank
I
you
have
for joining.
joined. I was listening
Yeah,
to
good morning,
Pankaj
sir.
Bhai.
Yes.
Sir, I am traveling to train, so Deepal will take over.
Okay, let us start. Welcome, Gunwan bhai. Thank you. Viraj,
Thank you.
let us start.
Good morning, respected faculties, esteemed moderators and examiners. I'm going to be presenting a case on peripheral vascular disease. So the patient is a 60-year-old female patient, homemaker by profession, Hindu by religion, residing in Veeraval, Gujarat, belonging to the low socioeconomic status. She presented to the OPD with the chief complaints of blackening on the plantar surface of her great toe since the last 3 months, pain in her left leg while walking since the last 1.5 months. On elaborating the origin, duration, and progress, the patient was asymptomatic before 3 months when she faced trivial trauma to her left great toe, after which she developed a small raw area on the plantar side of her toe. Following this raw area, there began blackening from the underside of the toe, from the side of raw area, slowly increasing towards the tip of her great toe. It was painless and associated with loss of movement of the toe. However, it was limited to the great toe without any extension. The pain in her left leg was insidious in origin and gradually increasing in intensity from mild to its current moderate state and is localized to her calf. The pain is bearable and the patient can walk with the pain with minimal additional effort. The pain appears only after she has been walking for approximately 100 to 200 meters, and it disappears on rest, and the pain reappears on walking again for the same effort. The patient consulted a local doctor for the pain, for which she was prescribed painkillers, and for the raw areas, the dressing was done and a topical antibiotic cream was applied. And as the blackening of the toe was increasing, the patient was advised to undergo a CT angiography of both the lower limbs, and based on the results was advised to consult a vascular surgeon. She was then referred to CHA, where she underwent a left popliteal embolectomy and since has noticed a reduction in the pain. Negative history. There is no history of similar complaint in the past. There is no history of rest pain. There is no history of similar complaints in the opposite leg. No history of any syncopal attacks, headache, loss of vision, abdominal pain, chest pain, and breathlessness. There is no history of fever, malaise, and body ache. and no family history of similar complaints. The medical history, the patient is a known hypertensive since the last 10 years, taking tablet chlorthalidone, 12.5 mg 1 BD. She's a known hypothyroid since the last 10 years, taking tablet Thyronorm, 25 microgram 1 OD. There is no history of diabetes mellitus or blood transfusion, and patient has a surgical history of tubal ligation 20 years back. He has a mixed diet with appetite which is adequate, disturbed sleep, regular bowel and urinary habits, and a history of tobacco chewing, 1 packet per day since the last 20 years, but has stopped since the last 3 months since the onset of complaints. Yes, sir.
Experts, would you like to
Viraj,
ask?
you have finished your history.
Yeah.
Yes, sir. Finish the history.
Okay.
So can we go back to your first slide?
Yes, sir.
Gunwan bhai, I think you are inaudible. You are not
Yes.
audible.
Hello. Now.
Yes. Now, yes. Now, yes.
Yes,
Yes,
yes.
please.
Yes. What are the chief complaints, Viraj?
Sir, she presented with the blackening on the plantar surface of her great toe since the last 3 months, with pain in her left leg while walking since the last 1.5 months.
Okay. So can you enumerate common causes of pain in the leg in female patients of this age group?
Sir, as the female is a 60-year-old female, sir, pain in the left leg can be because of onset of osteoarthritis. Sir, can be because of any disc prolapse which has caused any sciatica in the left lower limb. Sir, can be because of any nutritional deficiency that has occurred, sir, like vitamin B12 or iron deficiency anemia, which has resulted in pain. Or, sir, can be because of fatigue which causes the pain. And, sir, atherosclerotic changes which cause peripheral vascular disease in this age group.
You have mentioned musculoskeletal and other pains. What about arterial, venous, lymphatic, and other neurological causes?
Yes, sir. Patient can have.
What are the arterial causes?
Sir, atherosclerosis can, this age group, sir, she can have atherosclerosis.
She can have an thrombotic occlusion, right? Because you mentioned in the later part that she underwent embolectomy.
Yes,
so there can be a local in situ thrombosis. So don't mention only atherosclerosis. Mention atherothrombosis or thrombosis or embolism from some cardiac cause. Okay.
Yes, sir. Yes, sir.
Rajesh is speaking. Because I don't know who are they.
Rajesh Hyderabad. He is Dr. Rajesh.
Yes, Rajesh.
Yes, Gunan bhai.
So he did not cover this. Viraj, how will you differentiate between acute ischemia and chronic ischemia by this kind of pain?
Very good
vascular disease.
Sir, in acute. Yes, sir. Sir, in acute limb ischemia, the history of complaints will be very short, sir. In the
very short means what?
Sir, 6 hours to the acute onset.
Rajesh,
yes.
Viraj, do not use the terminologies like very short. Acute definition is?
So less than sudden onset, sir, less than 2 weeks.
Yes, it is generally sudden without any previous symptoms. That is very important.
Yes, sir.
And what is chronic?
So chronic is when the patient has had persistent symptoms since more than 6 months, sir. More than 3 months history.
See, you are Viraj, you are stuck on time. See, here what is important is gradual onset of symptoms or sudden onset of symptoms. That differentiates acute or chronic. Okay.
Yes, sir.
And acute on chronic means there is a gradual onset of symptoms, whether it is months or weeks or that's not important. Gradual onset with sudden worsening. That is acute on chronic. Okay.
Yes, sir. Yes, sir.
So use these three terms.
Okay. Sir, so the gradual onset of symptoms. Yes, sir.
Viraj, that is why I corrected your term definition of acute, and Rajesh Bhai has very well elaborated acute on chronic and chronic. So for any surgical resident, when you are seeing peripheral vascular disease, it becomes very, very important to differentiate these three things by history only. So now, can you tell me in your patient, which type of ischemia you are suspecting?
Sir, I'm suspecting chronic limb ischemia, sir, because it has
chronic limb ischemia.
Yes, sir.
Why chronic?
Sir, because there is a gradual progress of symptoms which has occurred over the last 3 months, sir, without any sudden deterioration. So there is associated blackening on the great toe.
No. Sudden deterioration on chronic and gradual onset of this kind of symptoms is known as acute on chronic.
Yes, sir.
Because there is sudden deterioration when patient was complaining of chronic and gradual persistent symptoms. Okay.
Yes, sir.
So what is intermittent claudication? Was she having any intermittent claudication?
Yes, sir. She had intermittent claudication. Sir, intermittent claudication is the cramp-like pain which develops in the leg because of the decreased perfusion to the muscles and accumulation of the toxic metabolites. And the pain is because of the substance P, which gets accumulated, sir, which is the intermittent claudication. It occurs as a result of decreased perfusion of the muscles because of peripheral vascular disease.
Viraj, you are right. You have said everything right. But when you are asked about the definition of any symptom, you should describe the symptom in detail. Intermittent claudication is intermittent and it appears on walking or exercise, and it is absent on rest. These three things are must. You understand?
Yes, sir.
Then you can say the causes and mechanism and all. Okay, which are the grades of intermittent claudication?
Sir, grades of intermittent claudication, sir, the grade 1, sir, when pain occurs for walking for long distance, and the patient can move without the pain, can move with the pain. So grade 2, the patient has pain but on walking, but can walk with some effort and does not require the rest. Sir, type 3, when the patient has pain on rest and cannot walk despite, sorry, sir, the grade 3, the patient has pain while walking and the pain is unbearable and the patient cannot walk even with effort and has to take rest.
What is rest pain?
So rest pain is termed as a cry of the dying nerves. Sir, it is the pain which occurs especially around the foot, the toes, because of the decreased perfusion to the nerves. And it is the pain which occurs at rest, especially increases during the night. And the patient gets relief by putting the legs down. Because of the gravity and is helped by the gravitational support of the pain relief occurs when the patient.
Again, Viraj, you are making the same mistakes you are making in intermittent claudication. Rest pain is to be defined as continuous and persistent boring and jarring pain, which occurs in the farthermost areas of the extremities. That is the definition. Rest of the things you have said right, but these things are must in your description. Why rest pain occurs?
Sir, rest pain occurs because of the ischemic changes which occur to the, so because of the blockage of the arterioles which supply the peripheral nerves. Sir, it results in that.
So what is venous claudication or venous rest pain? So it is not only atherosclerotic or arterial. You have to, there is lack of perfusion of the tissues which should be supplied. So it can be either arterial or venous, but you have to mention that. Okay.
Yes, sir.
So what is venous claudication?
So Viraj, when venous obstruction is there, there is venous congestion which reduces the tissue perfusion and that produces claudication, pain similar to the ischemic or arterial claudication, and that is what is known as venous claudication. Okay, because of excessive venous congestion, right?
Yes, sir.
Dr. Viraj?
Now go
Yes.
back, go to next slide.
Yes, Dr. Viraj.
Yes, sir.
What is the importance of the occupation in a patient presenting with a leg pain?
Sir, importance of occupation is, sir, the type of occupation will determine.
You have written homemaker. What do you mean by homemaker?
Sir, she's a housewife, sir. And sir is at home the entire day.
So homemaker is whether she makes home, whether she builds home. So homemaker is not a proper word, I think.
It is politically correct word, sir. Housewife. No, housewives object to this term housewife.
This
so they
terminology,
use
yes, yes.
homemaker.
Viraj,
But Rakesh Bhai has asked very good question. Huh? Viraj, you must be in a position to elaborate the type of occupation and relation and significance with the peripheral vascular disease. Please.
Yes, sir. Sir, if the patient has a history of prolonged standing for long hours, sir, it can present with prolonged standing for long hours. Sir, she can present with any venous disorders. Sir, again, if she's a homemaker, any small amount of trivial trauma to the limb can go unobserved and will eventually can result in peripheral vascular disease. Sir, these are the main sir, associations with being a homemaker. Sir, otherwise,
Viraj, yes, can we go further?
yes, sir.
Yes.
Yes. Viraj, you have mentioned blackening since 3 months and pain since 1.5 months.
Yes, sir.
How can you explain? First blackening appear and then pain appear?
Yes, sir. Sir, there was a blackening which developed before. Sir, might be because of so the pain would not have occurred initially because of the collateral formation. And sir, eventually the blackening was.
No. I don't agree with this statement. Pain would not have occurred because of collateral. What do you say, Rajesh Bhai and Tarun?
I think Viraj, Gunwant sir is right in his statement. Whenever there is a tissue loss, gangrene means tissue loss.
Yes.
There is a necrosis of the skin. So whenever there is a necrosis, it is associated with those 6 P's: acute limb ischemia or acute on chronic or chronic. Chronic can be critical, it can be non-critical. So these are the all different varieties as sir had asked. So first I will clarify, acute limb ischemia is symptom onset to up to 14 days.
Yes, sir.
Symptom onset up to 14 days of clinical presentation is acute. Beyond 14 days, it is chronic. So whenever there is a tissue loss, patient will get pain. But in your circumstances, like was she diabetic?
No, sir, she's not diabetic, sir.
So one is diabetes, second is elderly patient in which there is already a neuropathy component.
Yes, sir.
So the pain perception is lost. Even if you have noticed a silent asymptomatic gangrene, you have not realized that. But once you start having pain, you realize something bad is going on.
Yes, sir.
So she must be having some kind of pain at least. She might not have noticed very remarkably because she might not be working very hard or not doing any exercise. You said she is 60-year-old and homemaker. So that is the possibility that she has not felt chlorication and straight away blackening appear. Okay.
Yes, sir.
So now she has raised pain and blackening.
Can I interrupt?
Yes.
Apart from the discussion is going great, what I wanted to point out to Viraj is this is not the way to present a case like this. Origin, duration, progress. You have made it so elaborate, it is not required. From tip of the great toe and like that, just make it short and sweet. That's what I believe. He has detailed so much of detail. He had consulted cardiologists, this, that. I don't think that is a part of your history taking. This is too much of details you are giving. Underside of the side of the row area like that. I don't know how the patient has given you this history. I would really like to know that. Okay, this is just I wanted to make a point for all PGs. Such a detailed history will be a death of you. Okay. How did you find out underside this, that? So make it short and sweet. Great toe, take it as a great toe, like that. You are just, how much detail he has taken. That's what I wanted to just point out. Sorry, please continue.
Right, Pankaj bhai, right. Absolutely agree.
because that's what I was initially observing and waiting for somebody to make comment. So Viraj, take this important point that this much history, it is not, we are here not to impress anybody. We are here to state real facts. That's it. Okay.
So the message is very clear, Viraj, that you should mention only things which are required. Don't go into the minute or microscopic details that can put you later on in trouble. Okay?
Yes, sir.
So pain in her left leg was insidious.
Yes, sir.
Okay. Now, so what do you think this ischemia is? Your patient has grade 4 intermittent claudication, some rest pain, and tissue loss.
Yes, sir.
Based on this, what kind of ischemia you label it as?
Sir, I'd label it as a chronic limb ischemia. Or, sir,
Yes.
a chronic limb ischemia, sir. Because
What is
of the
critical limb ischemia?
So critical limb ischemia is sir, presence of rest pain with gangrene and a non-healing ulcer lasting for more than 2 weeks is critical limb ischemia. Sir, beyond which there will be tissue loss and a risk of amputation increases.
You have everything here, no?
Yes, sir.
Then why
Okay,
chronic?
next.
Why not critical? You
Yes.
mentioned critical limb ischemia, na?
My question was very leading. At this outset, you have said it is critical.
Yes, sir.
You understand, Viraj?
Yes, sir.
That was a leading question. You should have got the hint and said that it is critical.
Critical limb ischemia. Yes.
Okay, proceed further. Next slide. Acha, this kind of details are not required. Patient consulted this, then that. Okay.
Yes, sir.
Why, in your opinion, previous slide. You have said that she underwent left popliteal embolectomy. If we have the details, as Pankaj Bhai has said, we can discuss if we have the details. Do you have the details of popliteal embolectomy in this patient? Because patient is in our department, no?
Yes, sir. The details of the surgery are not there, but sir, the CT plate is there. Sir, of the
CT we will discuss in
investigations, yeah.
part. No problem.
Yes, sir.
But she
can
underwent
go to
left
the
popliteal
exam.
embolectomy. When it was done?
Sir, it was done, sir, 15 days back, sir.
15 days back. Okay. Next slide. Negative history, okay. Rajesh bhai, you want to ask anything in negative history? Tarun bhai?
Yes, Dr. Viraj.
Yes, sir.
Yes, Rakesh bhai, yes.
Yes, Dr. Viraj, can you explain each negative history? Why you are asking this negative history? What is the importance of it?
Yes, very good exam point of view question. Yes.
Yes, sir. Sir, no history of similar complaints in past, sir. Whether the patient has had any history of embolic change. Sir, if this is a type of recurrent thrombotic episode which has occurred in the patient, sir, if so, then sir, we will have to evaluate or investigate the patient further. Sir, a history of rest pain means, sir, it's not, sir, because there is no rest pain, there is no severe progress of the peripheral vascular disease. So complaints in the opposite leg will help us to determine the location of the block, if at all present, and the anatomical location of the blocks wherever they are present. So history of syncopal attacks, headache, loss of vision, abdominal pain, chest pain, or breathlessness. So this will rule out if the patient again has had any embolic or thromboembolic episodes, and can also rule out presence or absence of any cardiac disease such as any arrhythmias or thrombi which have been, or vegetations present in the heart. So fever, malaise, or body ache, again any septicemia which is associated, or there is any changes of wet gangrene in the blackening part. And sir, family history of similar complaints, sir, if at all there is any family history present inside the patient, or if present, sir.
What is the purpose of a negative history in general?
So negative history will help us to rule out the rule out certain things and can help us come to the diagnosis by negating the different causative factors which take part in a particular disease.
And its complications also.
And yes, sir, and its complications.
Okay, continue. Yes, continue.
Yes, sir.
So, can we go to the examination now? Or...
Viraj, please go to the next slide.
Next slide, please.
Examination.
So can I start with the examination, sir?
Yes,
Yes.
Sir, I examine the patient in adequate lighting with full informed consent of the patient and relative and in presence of a female attendant. So the patient is fully conscious, following verbal commands and oriented to time, place, and person. The temperature is normal. Pulse is 80 beats per minute in the radial artery of both the hands, regular, with good volume and good tone of the vessel, with no apex pulse deficit or radioradial or radiofemoral delay. So the blood pressure is 140 by 90 mmHg in the right brachial artery in sitting position. So there is no pallor, no icterus, no clubbing or cyanosis, and no lymphadenopathy noted. Sir, on systemic examination, the patient in CNS examination, patient is conscious, following verbal commands and oriented to the time, place, and person. CVSR S1 and S2 are normal with no additional heart sounds noted. And in RS, there is bilateral air entry, which is normal, and chest movement is equal on both the sides. Sir, on local examination, on inspection, there is blackening with mummification and drying of the left great toe, and blackening involving whole of the plantar surface and distal 2/3 on the anterior surface until the nail bed. The nail of the great toe is brittle. So there is a line of demarcation which is noted at the distal 2/3 and proximal 1/3 of the toe. Movement of the toe is absent at the metatarso-pharyngeal joint, and signs of chronic ischemia in form of brittle nails, loss of hair, and reduced girth of the toe is also noted. The part of the foot above the level of gangrene appears normal without any color change. Noted. Sir, the Burgess postural test was performed, which showed limited pallor at angle more than 45.
Can you show me the picture of this patient's foot if you have, because you are saying part of the foot is normal.
Yes, sir.
It is very unlikely in such case that the foot will be normal.
And you have mentioned in your examination there is loss of hair, there is thinning, signs of. So you are contradicting yourself.
Yes.
Yes, sir.
Anyway, you have to have some signs of ischemia, no? Skin and skin appendages.
Yes, sir.
You should mention it. And there must be some amount of muscle wasting also. And Viraj, you have also not mentioned the performance index. You know what is performance index? How the patient performs in her day-to-day routine and other.
Sir, there has been a reduction in the performance, sir, because of the pain.
That you have to specially look for, because it is very, very important, no?
Yes, sir.
In a case of peripheral vascular disease, when patient is not moving, not sitting, may not be standing, may not be walking, we don't know. So you have to mention it.
Yes, sir.
Go ahead.
Sir, on palpation, the temperature on the gangrenous part was cold until the line of demarcation with normal skin temperature from the base of the toe proximally till the hip. So capillary refill time was adequate. Venous return was also adequate. So the dorsalis pedis and anterior tibial artery had absent pulsation. The posterior tibial artery, popliteal and femoral artery pulsations were normal. The pulse is of good volume in nature and tension with no delay with good vessel wall condition. Sensations on the great toe were lost, whereas sensations in the remaining limb were normal. So movement at the metatarso-phalangeal joint of the great toe were absent, whereas the movement of the metatarso-phalangeal joint of the other toes and movement at the ankle, knee, and the hip joint were in normal range of movement. Tone and power of the lower limb were normal. No palpable inguinal lymph nodes were noted in the inguinal lymph nodes. And as compared with the opposite limb, there was no muscle wasting in form of loss of curl, which is noted at the level of calf and mid thigh, as 35 centimeters in the calf and 65 centimeters in the thigh. Yes, sir.
So you have examined this patient after the popliteal embolectomy or before the popliteal embolectomy?
Sir, after the embolectomy.
Okay. All right, go ahead.
Yes, sir.
So your examination is finished?
Yes, sir.
Okay. So now that the patient you are present, can you submit in a short while? What do you think?
Yes,
what is the status right now?
Yes, sir. She's a 60-year-old female patient with dry gangrene of the left great toe, with changes of chronic limb ischemia in form of brittle nail and loss of.
The audio.
Hello.
Yeah, you're audible.
Yes,
go ahead.
Sir, she's a 60-year-old female patient with dry gangrene of the left great toe, with changes of chronic limb ischemia in the left lower limb in form of brittle nails and loss of hair, without muscle wasting, most likely to be atherosclerosis of the vessels of the left lower limb, sir.
Okay. So you mentioned that the dorsalis pedis and the anterior tibial are absent.
Yes, sir.
I lost
And
the audio in between.
Posterior tibial is palpable, popliteal and femoral are palpable, right?
Yes, sir.
So then what is the next plan of action for you?
The next plan of action is to get a Doppler, sir. In the management point of view, sir, next plan is to get a Doppler done to collaborate with the clinical findings. Sir, if in the Doppler, if there is a blockage in any artery, sir, I would like to do a CT angiography. So because I'm thinking it to be atherosclerosis, which affects the medium and large size vessels. Sir, and based on the CT angiography, sir, I would like to see the level of occlusion, which will determine the further treatment.
So
sir,
from your clinical examination, what do you expect the Doppler to show?
Sir, based on clinical examination, sir, I would expect that there is a loss of flow in the dorsalis pedis artery, sir, mainly. Sir, with decreased flow in the ATA, sir, otherwise normal pulsation should be present in the. There's a normal findings in the Doppler, in the PTA, in the posterior tibial, popliteal, and femoral arteries.
So basically, after the popliteal embolectomy, still the anterior tibial artery is not perfused. That is your finding.
Yes, sir.
Yeah. Okay. So the you are aware of the various arteries which supply which areas of the foot?
Yes, sir.
So grade 2 is involved. That means you have to reperfuse the anterior tibial artery to get adequate circulation, right?
Yes, sir.
And whenever you are mentioning this atherosclerotic obstruction, you have to add the component of thrombosis also. Always add that to that, because that is the terminal event which leads to critical limb ischemia in a case of chronic atherosclerosis. Okay?
Okay, sir.
Dr. Viraj?
Yes, sir.
You have written in summary. So what is your diagnosis?
Sir, diagnosis is chronic limb ischemia because of atherosclerosis of the left lower limb, sir. Atherosclerosis of the vessels.
I would change that chronic to critical.
Critical. Okay, sir. Critical limb ischemia.
Critical, because she is at a risk of losing her toe, right?
Yes, sir.
She's already lost it, rather. Yeah, gangrene.
Oh.
Viraj mentioned it as CCLI, critical chronic limb ischemia.
Yeah.
Yes, sir.
And in Doppler, Viraj, it is important to tell the radiologist to give you a good idea about the flow at the common femoral artery, whether the iliacs are good or not, was there any plaque embolization from the iliac artery to the popliteal artery or anterior tibial artery? What is the status of the collateral circulation, profunda femoris artery, superficial femoral artery? Everything you have to scan. Suppose there is not even a single amount of plaque in the proximal arteries, then still you would say it is atherosclerosis?
No.
Viraj? Opposite limb is normal, carotids are normal, upper limbs are normal. Patient is hypertensive and hypothyroid. She doesn't have diabetes. She is elderly, 60 years old. As Hyderabadi sir has mentioned, thrombosis is a very important component of these kind of presentations. All these patients are moving around whenever there is a plaque rupture. On top of that, there is an in situ thrombosis. Either it is a joint which is predisposing the popliteal artery for thrombus formation, or there is some mechanical factors. Sometimes these patients have a muscle bundle which is crossing the popliteal artery, which is called popliteal artery entrapment syndrome.
Entrapment syndrome.
So sometimes that causes an extrinsic trauma, just like cervical rib. It is causing a trauma to the subclavian artery. And you don't have any other risk factor anywhere. Cholesterol is normal, sugar is not there. So that trivial trauma damages the intima. And then there is an in situ thrombosis. Rajesh sir mentioned in the very first initial part of the lecture that in situ thrombosis is very, very common, like dehydration. She must not have consumed enough fluids. And that thrombosis then embolizes to the distal part, and then that becomes symptomatic.
Yes, sir.
So don't stick to atherosclerosis alone, okay? You will be in trouble if the examiner decides so, right?
Yes, sir.
Another thing, if you can go back to your history, you mentioned that the patient presented to the orthopedic surgeon or something, and then they straight away went for CT angiography.
Yes, sir.
So if the patient had presented to you at that stage, would you have gone for CT angiography or vascular arterial Doppler test, just like you presented now?
Sir, I would
first investigation should have been.
Sir, first investigation would be a Doppler, sir. Would always be a Doppler.
Yeah.
Yes, sir.
So that you should mention.
Yes, sir. First investigation would be a Doppler. So to
and when Viraj, we should resort to CT angio or any angio.
Sir, CT angio is helpful, sir, if it is involving the medium and large size vessels. And sir, if you are planning for any revascularization surgery, sir, which in any intervention, sir. Intervention, sir. Then CT angio will be helpful to see whether it is a short segment or a long segment block. And based on that, sir, either an endovascular approach or a surgical revascularization approach can be taken into consideration.
So Tarun Bhai has very nicely elaborated, but which are the various things we should look for in Doppler?
Sir, in the Doppler, sir, the phasic flow, sir, whether it is a triphasic, biphasic, or a monophasic flow.
Flow, Viraj, you are right. We'll see the flow, but first thing is the B mode sonography, in which we generally see the images, no?
Yes, sir.
What do you see there in the B mode?
He is asking you a leading question, Viraj.
Yes, sir. Sir, the
B mode. Are you aware of the term intima media thickness?
Yes.
IMT.
So the
you should be aware of this term.
Okay, sir. Yes, sir.
Tarun Bhai, you can elaborate to the PG students.
Viraj, see, the arterial wall is made of 3 layers. One is tunica intima, tunica media, and tunica adventitia. Once the intima ends, there is internal elastic lamina, and then there is a media. Outside the media, there is external elastic lamina, and then there is adventitia. So radiologically, you can't see the laminas because that is very, very thin, and the sensitivity of Doppler is not that you can see laminas. So what you see, intima, if it is thick, you see it as a thickened plaque accumulated area. Otherwise, you just see the tram track appearance of the vessel wall, which is smooth. and there is no calcification. You can see calcification, you can see thrombosis, you can see intimal medial thickness. Hyderabadi sir has mentioned, which is called IMT. It's a very, very good surrogate marker for atherosclerosis. If the IMT is increased, that means the patient is suffering from atherosclerosis. If IMT is normal, that means the chances of atherosclerosis are very less. Then third thing is the plaque distribution, whether it is a localized distribution or an extensive distribution of plaque. Fourth is calcification. These are the few things which you see in the B mode. D is brightness mode. You don't have any color.
Yes, sir.
It's just a plain ultrasound first view, which a radiologist would see, and then he will identify whether it is a vein or whether there is artery. How do you differentiate between vein and artery? Veins are collapsible.
Yes, sir.
Veins have phasic variation. In inspiration, the blood goes towards the thorax. In expiration, it doesn't go towards the thorax. Arteries are much more elastic. They are not compressible or collapsible. Veins are collapsible if they are normal. So these are the differences to differentiate between vein and arteries. And then you go for the further color examination, color Doppler examination.
Yes,
So
sir.
what do you see in color Doppler?
Sir, color Doppler, sir, any turbulence in the flow, which is noted across the site of obstruction. Sir, with turbulence, which is noted in the color Doppler.
Turbulence?
Sir, turbulence is the, turbulence is something which affects the flow of the blood across any obstruction, sir. In a narrow space, the blood will move via rapid force and increased force, sir, which will cause any alteration in the signal to the Doppler.
So Viraj, doing color Doppler is a very time-taking process. You have to go and examine right from inguinal region up to the ankle, no? Sometime even beyond ankle. So it is time-consuming as well as it is operator-dependent who is doing it and what knowledge of doing and experience of doing color Doppler he or she has got.
Yes,
so
sir.
when you are doing this, you have to not only see the sites of obstructions or the narrowings, but also see the normal flow also. So normal velocity, abnormal velocity, normal flow, abnormal flow, and the sluggishness of the flow, then the phases of the flow, everything you have to see. Turbulence is something different, but velocity is very important.
Yes, sir.
So be careful when you present in examination. Don't go jump to turbulence. What he is telling is that you have to mention the flow, normal flow, biphasic
First
flow.
you mention the normalcy, yes.
Yeah. Okay.
Yes, sir.
Okay. Go ahead.
So in this case, Viraj, if you have or if we have a report of the color Doppler, I think it would be better to see.
Sir, I have a photo of the CT.
Can you share? Yes, yes, you can share whatever you have.
Yes, sir.
You can read the Doppler report if you have it. If you don't have a slide.
Sir, I have a photo of the.
Can you share it?
Yes, sir.
CT angiography.
Yes, sir.
अच्छा ये तो एंजियो है. No, I was talking about Doppler.
Sir, Doppler, sir, report is not there, sir.
Don't have. Okay, doesn't matter.
So
let us go to this.
This angio is post-embolectomy?
Sir, this is the post-embolectomy, sir. And sir, the previous was...
It seems
but you mentioned the popliteal was palpable and postiotibial was palpable.
So that was post, yes, sir, that was post-embolectomy, sir.
So this seems to be pre-embolectomy?
Yes, sir, this is the pre-embolectomy, sir. This one is the pre-embolectomy.
On left side, right from superficial, we can't see anything. Yes, there are collaterals. Yes,
sir, collaterals. Yes, sir.
So can you read this CT? Whatever you can comment on this.
Yes, sir. Sir, this is a CT angiography of the patient, sir, in which the pathology appears to be on the left side with complete occlusion below the around the knee joints. Most likely to be the.
No, it is not the knee joint. When you say occlusion, you have to mention the artery and the level.
Viraj, always start from the proximal.
Which artery?
Go to the distal. You start from the distal, go to the proximal. Don't pick from in between. So you are seeing the intrarenal aorta?
Yes, sir.
Very nicely, suprarenal aorta is seen, celiac axis is seen, superior mesenteric artery is seen, right renal, left renal is seen, then infrarenal aorta, then aortic bifurcation.
Yes, sir.
Then in aortic bifurcation, common iliac
This is
artery.
the way of looking at it, Viraj. Huh?
Yes, sir.
Then the bifurcation of the common iliac artery divides into internal iliac or hypogastric or external iliac artery. Then from external iliac artery, you go to the common femoral artery. At the level of inguinal ligament, it makes a transition. Then from the common femoral artery, there is a unbranching vessel and then there is a branching vessel.
Yes.
Branching vessel is profunda femoris or deep femoral artery.
Yes, sir.
And then superficial femoral artery, you see.
Yes, sir.
Your CT has disappeared, Viraj.
Yes, sir. Sorry, sir.
So, are you able to see the common femoral artery?
Change the view.
Share slide.
Viraj, share the CT plate.
Yes, sir. Yes, sir.
Yes, good.
Keep describing now the common femoral artery. I think from the ostium, the superficial femoral artery is not visualized on the left.
Occluded, yeah.
And you can see specks of the outer wall, whether it is a calcium or not, we can't make out in the angiographic film. For that, you have to go for the MIP image or the raw images or the axial images.
Yes, sir.
But the block is right from the common femoral.
So origin of superficial femoral, sir. There is a nipple in there. Origin of superficial.
Yes, a little bit nipple in of deep femoral. Yes.
And then Viraj, go to the adductor canal area. You can see some formation of the arterial tree. A small 2 centimeter area is visualized, and then again the femoropopliteal junction is not visualized. Popliteal artery prior to the joint, across the joint, below the joint, it is not seen. And then once you go below, the popliteal trifurcation has to be seen. So popliteal divides into which 2 branches, Viraj?
So popliteal into the tibial artery and the peroneal arteries.
Anterior tibial artery and the
Peroneal.
tibio-peroneal trunk.
Tibio-peroneal trunk.
TPT, tibio-peroneal trunk. And tibio-peroneal trunk divides into?
So the posterior tibial and the
deep peroneal.
Deep peroneal.
Deep peroneal. And dorsalis pedis is a branch of?
So anterior
tibial.
Yes, sir.
And there is a collateral circulation between the posterior tibial and anterior tibial artery through the plantar?
The plantar arch.
Plantar arch.
Good.
So this lady has an extensive femoral artery. It is very, very important to have a look at the post embolectomy picture. As per the age, I think it looks like an in situ atherothrombosis, which Hyderabadi sir has pointed out. And the rest of the vascular tree on the right side, iliac, aorta, you don't see anything.
Yes, sir.
So it is not a systemic atherosclerosis, it's a localized problem. And whosoever did the embolectomy, they thought it is a popliteal area, but it is a whole femoral artery, which is occluded, and popliteal arteries occluded. So at that point of time, whatever surgeon decided and did, I think that was a great job. Now you are saying popliteal artery is palpable, but the anterior tibial is not palpable. It would be interesting to see the imaging.
That's what Tarun Bhai, Rajesh Bhai and Rakesh Bhai, he mentioned in his examination that femoral and popliteal is palpable on left side. Now I doubt.
So this is pre-operative angio, CT angio, Gunan Bhai.
Yes, sir.
He doesn't have the current picture.
But operation was popliteal embolectomy, and it was done through might been done through femoral. No?
Dr. Viraj?
Yes, sir.
Doctor, how popliteal embolectomy was done?
Sir, it was an incision which was placed below the knee joint. Sir, and the popliteal artery was exposed there. And sir, both proximally as well as distally, sir, the Fogarty was passed and the embolus was removed.
Okay.
Previously, you said it is details are not available.
Sir, only the operative findings in the case paper were there, sir. Otherwise, sir, no exact details of sir, whether the thrombus was removed or not is written, sir.
Do we have post-embolectomy CT plates?
Or any Doppler examination also will do.
Whatever we have got.
Sir,
this have, I think you can share.
Sir, this was the picture which was done post embolectomy. But sir,
oh, this is post embolectomy.
Yes, sir.
And still you are palpating femoral and popliteal in this case. That is why.
My God.
I think Viraj, now there is a very gross discrepancy between your clinical examination and investigation.
Post-embolectomy.
Sir,
was posterior good enough, palpable?
Sir, it was feeble, sir. Could not palpate it, sir, as like the femoral pulsation, sir. But it was.
You have a patient right now in your ward?
No, sir.
See the advantage of PowerPoint presentations. You can't confirm anything.
So Viraj, basically what you mentioned is atherosclerotic. Then you mentioned there is a popliteal embolectomy which was successful, and you have mentioned palpable popliteal. So that throws that atherosclerosis, and as Dr. Tarun Madan said, no evidence of any atherosclerosis in aorta or on the right lower limb vessel.
No other artery.
So that puts you in the favor of acute thrombotic occlusion as the primary disease, right?
Sir,
so your whole atherosclerosis theory goes out of the window as per your clinical findings and history, right?
Yes, sir.
So Viraj, can you or do you want to revise again your clinical diagnosis? Because now it is the picture is very clear after imaging, no?
Yes, sir.
The clinical diagnosis has a limited value. We all know that, but can you revise it now?
Sir, it is a 60-year-old female patient with critical limb ischemia. Sir, with acute,
left lower limb, yes.
Critical limb ischemia of the left lower limb, sir, with acute thrombotic changes in the left lower limb vessel, sir, with occlusion with thrombotic changes at the level of the femoral artery.
Okay. But the presence of collaterals goes against an acute event, right? Because these collaterals are reasonably well developed. Yes, she has distal perfusion.
I do not agree with the acute thrombosis. Huh? It is definitely very good collaterals have formed all around. And the duration is 6 months.
So more than 14 weeks, 14 days. 3 months was the history of beginning of symptoms.
3 months is
chronic. Sir, acute on chronic. Sir, could it be acute on chronic change?
It's definitely a chronic thromboembolism.
Yeah, acute would have presented with rest pain. Yes. Only intermittent claudication goes in favor of chronic.
Viraj, there is very, very important thing in clinical examination to check the pulse oximetry. I think you have missed on that aspect. You check for the pulse waveforms on the right great toe or the right second, third toe and the left second and third toe. If there is a decreased amplitude of the waveforms, that means the perfusion is decreased. And second is handheld Doppler. If you are not able to palpate the popliteal artery or the posterior tibial artery, so there is a very good device It's a handheld Doppler. If you are able to hear the Doppler sounds, that means the limb is getting adequate perfusion. So these two things also should be kept in mind while examination. Pulse oximetry, which is simple saturation of the toe, and then handheld Doppler.
Yes, sir.
These are done bedside, so these are part of your clinical examination.
Okay, sir. So we'll add. Yes.
Now, Viraj, what would you plan for this patient?
What are your options?
Sir, treatment options. Sir, first, sir, I'll start her on medical line of management. Sir, with aspirin, sir, I mean antiplatelet drugs.
Viraj, still you have not shown me the clinical picture of the foot and the limb. Huh? Where is the line of demarcation?
You have a picture of the foot?
Yes, sir.
Yeah. Because without seeing the limb, how can I decide any further plan?
Yes, sir. Sir, I'll show it.
I think you should incorporate in your PPT a still picture of the front.
All PowerPoint presentations must incorporate clinical photography without revealing the identity of the patient. Anterior, posterior view, lateral, medial,
and a small video of the toe movements.
If possible, video of various testing you have done.
Perfect, perfect, Viraj.
See, this is not the good picture, I would tell you, because you have not shown up to knee. And only one view. What about posterior surface? What about lateral, medial?
Yes, sir.
When you are presenting a PowerPoint case, you must do this.
Was in your history you mentioned only plantar surface. Here the whole thing is gone. Eh?
Yes,
sir, plantar and sir, up to the
has gone.
Base of the great toe, sir, up till the nail bed. Sir, mentioned in the history.
Means dorsum and plantar both are gone, na?
Yes, sir. Up till the nail bed, sir. Had it, sir.
And what is this discoloration on the front of ankle? And see the edema and the wrinkling and redness.
Sir,
there are so
the skin mark was present since birth, sir. That is what the patient has said. I mean, it was present since
when you started local examination, I pointed out of showing me the clinical photography. Anyways, the foot is not all normal. Huh? You said everything is normal. So there are lacunae in your clinical examination and presentation. Anyways, let us concentrate ourselves to the Tarun Bhai's question. What is your further plan of management?
Sir, I'll start the patient on antiplatelet therapy with aspirin and clopidogrel. Sir, with a plaque stabilizer and atorvastatin. Sir, so this will be the basic medical management. Sir, with sir, plan for revascularization at sir, revascularization
what about anticoagulation?
Sir,
will you give any intravenous if the patient is hospitalized or anything oral?
Because you mentioned popliteal embolectomy.
Sir, warfarin.
Perfect. Okay.
So
you would prefer warfarin. Straight away warfarin or any other injection prior?
Sir, 5 days overlap between warfarin and intravenous heparin or low molecular weight heparin, and then sir will start with warfarin.
Any other option if you do not want to use warfarin?
Sir, newer drugs such as dabigatran or rivaroxaban, sir, or acetrom, sir, no camelon derivatives can be used.
Okay. Then anything to improve the rheological index of the red blood cells?
So silastazole or pentoxifylline
can be added as an add-on therapy.
Can be added as add-on, yes, sir.
And for pain management?
So pain management, sir, non-steroidal anti-inflammatory drugs, but seeing at the age of the patient, sir, sir, gabapentin, which will also take care of the neuropathic pain, if present, sir, can be used in this patient.
She doesn't have neuropathic pain.
Paracetamol and tramadol combination can be used, which is a safer option to the NSAIDs.
Yes, sir.
Then your neuropathy, pregabalin or methylcobalamin combination or nortriptyline combinations. And foot care, what would you advise this patient as a foot care?
Sir, foot care, general foot care measures, proper footwear, sir, maintenance of hygiene.
Do you think she can wear a footwear in this condition?
Say no.
No,
Just say no.
No, sir. Sir, keep away from moist.
Avoid water contaminants.
Sir, so don't keep the leg water.
Keep it dry.
Viraj,
Dry and
Viraj, can you see those big nails?
Brittle nails.
brittle nails.
What will you do? Because Tarun Bhai has asked about foot care, no?
Yes, sir.
So
Nail
as surgeon,
clipping.
it is very, very important. Prevention, treatment, and again prevent the reoccurrence of disease. So would you trim those nails with some mechanism or something like that? Because
Yes,
if the nail gets avulsed, again it will be a non-healing ulcer.
Non-healing ulcer. Yes, sir. We'll take care of the nails.
Moisturize the skin
clipping.
of the leg.
Yeah.
What about sole of the foot? Is it normal or like this only?
No, sir. Sole is normal, sir.
And the heel pad?
Sir, it is also normal, sir. Only the sensations have reduced. Sir.
Are there any skip lesions or skip
No,
areas?
No, sir. No, sir. The gangrenous changes are limited only to the great toe.
In the leg or in the
No, sir. No skip
knees
lesions.
or in the thighs?
No, sir. It is limited only to the great toe.
So Viraj, what is your basic plan? I mean, this patient has come to you as a clinician. So what are you intending to do, or what you need to do? Can you summarize it in 3 lines or 2 lines maybe?
Sir,
That is what will decide your plan of action, right? So basically she has a gangrene of the toe. So she needs an amputation, right?
yes.
Right?
Will you do amputation or not?
it's-
That is the
Sir, it's a dry.
Sir,
It's a dry gangrene, sir. Sir, without any
So
wet
she-
changes, sir, I would not go for an amputation straight away, sir.
No, straight away or no straight away, but eventually this toe has to come out, right?
Yes, sir.
So, but then you want your amputation stump to heal
Yes, sir.
without any problems.
Problem, yes, sir.
For that you need
So proper
adequate vascular supply, right?
Yes, sir. Yes, sir.
So for that you are looking at the vascular tree,
Yes,
where
sir.
you can intervene and how you can increase the blood supply to that stump of the great toe. That is your plan of action. So everything that you do, whether you give aspirin or whether you give warfarin, so that the purpose is to
Increase the
re-establish
blood
the blood supply to the great toe and achieve healing of the amputation stump that you are going to perform. And for that, then the sequence of event, whether you will revascularize first, whether you are going to do amputation first, everything is decided by your plan of action. Okay?
Yes, sir.
So that should be very clear in your mind, the sequence of events, right?
Yes, sir.
Okay, go ahead.
So Viraj, abhi, right now you will ask this patient to undergo amputation. You wait for some time for the medical therapy to act, improve the collateral circulation to the infrapopliteal tree, then ask the lady to undergo amputation. Which kind of amputation would you do? Remove the great toe, then wait for the stump to heal. If the stump doesn't heal, then you go for transmetatarsal. If that doesn't heal, you go to BK or you go to AK. What would be your plan which you will counsel to the patient?
Sir, right now, because in this scenario, so the patient has a still dry gangrene of the great toe. Sir, so I would allow the medical line of management. I mean, I'll start with the medical line of management first. Sir, and I'll wait for a proper line of demarcation to appear. Sir, once that is fixed, sir, then I'll wait until any wet, because there are no wet gangrene changes. So we'll not go for amputation straight away. Sir, it will again auto amputate if dry gangrene is persistent with the line of demarcation. And sir, with the medical line of management, I'll wait for it to stabilize, and then sir will think of revascularization and then do a raised amputation.
Okay. I think majority of these patients, if you do a very good medical management, foot care, they auto amputate, it becomes dry, and there is a very good natural amputation which happens. And if it doesn't happen, then re-amputation, as you mentioned, it is the way to go. And if still the thumb doesn't heal, then you take help of Rajesh sir for a distal bypass.
No, I think Tarun, you can also do something.
So sir,
Please,
very extensive
elaborate for the benefit of pages. Which are the interventions, Tarun bhai, we can plan in this case?
Sir, suppose this patient has failed one procedure of popliteal embolectomy, and there is a whole occlusion of femoral artery from the ostium till the popliteal third segment and the trifurcation. So first option is we can do a balloon angioplasty, and if required, there is a thrombus component in the angiography. We can put a catheter and lyse the thrombus with the help of a thrombolytic drug. So once you lyse the thrombolytic drug, so not always putting stents helps in these patients. You have to remove the existing thrombus and prevent the reformation of thrombus. So existing thrombus can be removed by balloon angioplasty. Then lysing the thrombus, if it is a recent thrombus up to 2 to 3 weeks old, it can be lysed with the help of thrombolytic drug. So you can place a multi-infusion catheter in the femoral tree and then give a lysis over a period of 12 to 24 hours or maybe 48 hours. And then once the thrombolysis is done, overlap this with anticoagulation, heparin or newer anticoagulant like rivaroxaban or dabigatran or apixaban or warfarin or acetrom, whatever is available at your end. And then look whether the limb is warm, there is no loss of movement in any other great toe, then wait and watch and then plan for your amputation. But yeah, as you have already mentioned, the neurology of the great toe is gone. Rest of the toe, flexion extension of the foot, ankle movement, everything is preserved. So only issue lies at right now with the great toe. So option of balloon angioplasty, plus minus thrombolysis, which is CDT, catheter directed thrombolysis. And maybe if there is a flow limiting dissection, maybe a localized stent somewhere in the upper or middle or lower femoral artery.
So, Tarun bhai, question from my side, whether you would like to go in this case, suppose this patient is with Viraj right now and is sent to you, you will definitely go for balloon angioplasty and thrombolysis in this case?
If there is rest pain, only then. If there is no rest pain, no.
I think she has some rest pain. Viraj?
No, sir. No rest pain is present, sir.
No rest pain. So you will not do anything.
If the limb is warm, just keep her on medical treatment.
Right. And,
because it is such an extensive disease. In the process of doing an intervention, sometimes you embolize.
Yes.
Distal showering
of those muck will deteriorate the picture.
So all in all, intervention from your side in term of PTBD or thrombolysis is out of question right now.
Yes, sir.
Okay. So Rajesh bhai, revascularization, you were talking about revascularization. Would you like to do some arterial surgery in this case?
So if at all I am forced to do it, I will have to do a femoral-popliteal bypass surgically. But the popliteal distal runoff, the tibioperoneal trunk is very bad. So I'll end up with some sort of an endarterectomy or embolectomy. And if the back bleed is adequate, only then I would be able to perform a good femoral-popliteal bypass. So my choice again would be to, as Tarun bhai said, if I'm forced to intervene, I would go for the angioplasty and in situ thrombolysis. That would be my first choice, looking at the extension of disease. Okay.
Otherwise,
until then, medical. Yeah.
So
and
at
this
the end,
patient
what remains is the medical line of management.
Best medical line of management. Yeah.
Yes.
But then instead of adding any warfarin, I would add rivaroxaban and aspirin and statin and correct her whatever nutritional or anomalies are there. Ask her to stop chewing tobacco, which she has been doing for 10 years or so. Go for the this amputation of the great toe if required, and then wait and watch with frequent ultrasound imaging. to check for the adequacy of circulation. Okay.
Okay. Pankaj bhai, are you there? Apurva?
Sir, Dr. Dipali here. Pankaj sir has left for a while.
Okay,
So
okay,
he
no
will be
problem.
joining later on. Okay, sir.
No problem. Any questions from the PG side? Rakesh bhai, you want to say something?
Yes. Sir, what should be the proper clinical diagnosis of this patient for the benefit of all of us and PGs?
Yes, yes.
I think it should be a dry gangrene of a left great toe in the case of left femoral popliteal block due to atherosclerosis. It should be like this, that, or it should something else.
Atherothrombosis.
Atherothrombosis.
Yeah, there is thrombus.
Yes, yes.
Yes, I think that is the perfect diagnosis, Rajesh bhai. Rajesh was mentioning something about in situ.
Yes, in situ thrombosis of the femoral artery. Yes.
Okay, okay.
Should we include in a post popliteal embolectomy status?
Can be, yes,
I think
because
so.
it is there in the
yes,
history.
you have to.
Yes, yes.
Yes.
This is also an important point.
Yes, yes, very important. Viraj, you want to ask anything?
Yes, sir. Sir, the atherothrombosis that you have mentioned, sir. So this thrombus is from the atherosclerotic plaque, which was already present since before, sir, or is it a new onset of thrombus which has occurred because of any intimal injury or any trivial trauma to the vessel?
Intimal injury, yeah. It is intimal ischemia. See, the vasa vasorum of the femoral arterial wall that gets occluded. She's a known case of hypertension.
Yes,
so
sir.
hypertension is a microangiopathy. So the vasa vasorum of the femoral artery must have been occluded. That produces local ischemia of the femoral artery, the intima and the media, and that produces local arterial thrombosis. You can see that in post-COVID cases, vasculitis. You can see that in atherosclerosis, where the plaque ruptures and produces thrombosis. So the thrombosis is the terminal event. The underlying pathology is either vasculitis or vascular wall ischemia or atherosclerosis. Okay.
Yes, sir.
Viraj, I think you should include, as sir has already mentioned the diagnosis, Rutherford classification.
Yes.
Yes.
So critical limb ischemia, what is the Rutherford classification? 0 is asymptomatic.
Yes, sir.
1 is
Sir,
mild
sir,
claudication.
yeah, yes, sir.
2 is
Sir, associated with rest pain.
moderate claudication.
Moderate.
3 is severe claudication. 4th is
Lifestyle
rest pain.
limiting.
4th is rest pain. 5 is minor tissue loss. Your case. 6
Yes,
is major tissue loss. What is the definition of minor tissue loss? Non-healing ulcer, focal gangrene, non-healing ulcer or focal gangrene, localized, and major tissue loss below the transmetatarsal level. So again, you revise Rutherford. 0 is asymptomatic.
Yes, sir.
1 is mild claudication. 2 is moderate claudication. 3 is severe claudication. 4th is rest pain. 5 is minor tissue loss. 6 is
Major tissue loss. Yes.
So this is your Rutherford
Classification.
5. This patient is Rutherford class
5. 5. Yes.
So very good discussion, Rajesh bhai, Tarun bhai, Rakesh bhai, and all. So all in all, it was a good clinical case with good discussion of not only clinical but investigation and management part. Thank you all in essence of Pankaj bhai and Apurva. Dipali, you have to say something?
Sir, I would like to thank Dr. Hyderabadi sir and you, Dr. GHR sir, Tarun Madan sir, Rakesh
It's my
sir,
pleasure.
on behalf of on behalf of PRM sir and AGS sir. And I hope this discussion will help the PGs, the exam goings especially. And if any PGs have any question, we have the expertise available. I think the discussion has concluded everything, sir. So I
Okay, so
wish
we
you a very
conclude
good day.
here. Thank you.
Yes,
Thank
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 you
you,
so
sir.
much.
Thank you so much.
Have a good day.
Thank
also.
you. Thank you.
Thank you,
Thank
sir.
you, sir. Thank you. Thank you.